Hello guys, welcome back to my YouTube channel. From this video you will learn about the thyroid gland anatomy. I will talk about the general features, capsule of the thyroid gland, then the relations of the lobes as well as to the surface and the isthmus of the thyroid gland, then arterial supply, venous drainage, lymphatic drainage, as well as what is the clinical significance of the thyroid gland. This is the cervical region, and you can see the cartilages in the laryngeal area, and this is the hyoid bone. So, this is the thyroid cartilage, this is the cricoid cartilage. So, you can see thyrohyoid membrane here and cricothyroid ligament, median cricothyroid ligament here. This is the thyroid gland. You can see right lobe of the thyroid gland, left lobe of the thyroid gland, and isthmus of the thyroid gland. This part is the trachea. The thyroid gland is a highly vascular endocrine gland. It is situated in the lower part of the front of the neck, in close relation to the larynx and the trachea. The follicular cells of the thyroid gland secretes triiodothyronine, that means T3, and tetraiodothyronine, that means thyroxine, T4 hormones, which raise the rate of metabolism. These thyroid hormones responsible for our basal metabolic rate. The hormones are stored in the follicles of the gland as thyroglobulin, and parafollicular cells secrete calcitonin, which is a hypocalcemic hormone. So let's discuss about the general features of the thyroid gland. The thyroid gland weighs approximately 25 milligrams in adults, being slightly heavier in female. It consists of right and left lobes, which I told you earlier. It is connected by the isthmus of the thyroid gland. Each lobe is around 5 centimeters in length and 3 centimeters in breadth, as well as 2 centimeters in thickness. The lobes extend from oblique ligament of the thyroid cartilage. Lobes extend from the oblique ligament of the thyroid cartilage to the level of 5th or 6th tracheal ring. 5th or 6th tracheal ring, and corresponds to C5 to T1 vertebrae. This area is correspond to C5 to T1 vertebrae. The isthmus lies against 2nd to 4th, or we sometimes call 2nd to 3rd cartilaginous rings. In this area, 2nd to 4th or 2nd to 3rd cartilaginous rings. A small pyramidal lobe usually extends from the upper margin of the isthmus on the left side. Here, look at this picture. You can see this is the thyroid gland, and you can see small part. This is the pyramidal lobe. So, this pyramidal lobe extends from the upper margin of the isthmus on the left side. It may be attached to the hyoid bone. This is the hyoid bone by a slip of a muscle called levator glandulae thyroideae. This is the slip of the muscle. So, from this slip of muscle, which is called as levator glandulae thyroideae, this pyramidal lobe connected to this hyoid bone. The upward shift of an enlarged thyroid gland is arrested by the attachment of sternothyroid muscle to the oblique line of the thyroid cartilage. This area is the oblique line of the thyroid cartilage. So, the sternothyroid muscle, that means from the sternum of the manubrium, uh, from the manubrium, this sternothyroid muscle extends up to oblique line of the thyroid cartilage. Due to this attachment, when the thyroid gland is enlarged, the upward shift of the thyroid gland is prevented. The short neck and strong strap muscles are responsible for pushing the lower pole of a normally located but enlarged gland downward into superior mediastinum. Sometimes, if there is an enlargement of the thyroid gland, it can be go downwards into the superior mediastinum. We call it as a retrosternal goiter. Next, we will see the capsules of the thyroid gland. The thyroid gland has a true capsule which is fibrous. This is the true capsule. This part is the true capsule, so it is fibrous, and there is a false capsule. This one is the false capsule. This one is the true capsule, innermost one. Then this is the false capsule. False capsule is the fascial. That means it has made from the deep fascia of the cervical region. The true capsule is the condensation. This part, the true capsule is the condensation of the connective tissue at the periphery of the gland. The venous plexus lies deep to the true capsule. This is the venous plexus. This area is the venous plexus and this area is the thyroid gland. So you can see the venous plexus lies deep to the true capsule as well. The false capsule is derived from pretracheal layer of the deep cervical fascia. The pretracheal fascia is attached above to the oblique line of the thyroid cartilage. On the posteromedial aspect of the lobe, the fascial capsule is thickened to form suspensory ligament of Berry, which is attached to the arch of the cricoid cartilage. So you have to remember very well. The venous plexus of the thyroid gland is situated deep to the true capsule, deep to both capsules. That is the part you have to remember. I told you earlier a name of a ligament called suspensory ligament of Berry. This ligament holds the gland firmly in contact with larynx, and therefore it prevents from sliding down when enlarged. During surgical removal of the gland, the ligament of Berry must be identified and cut. The attachments of pretracheal fascia to the thyroid and cricoid cartilage and also hyoid bone are responsible for the movements of the thyroid gland during swallowing and speech. Let's discuss about the relations of the thyroid gland. Each lobe of the thyroid gland presents three surfaces and two borders. Three surfaces means one is superficial surface, that means anterolateral surface, that it is the superficial surface. Then it has medial surface. Here this area is the medial surface. Then it has posterolateral surface. This part is the posterolateral surface when we talk about the lobes of the thyroid gland. These are the two lobes. This is the superficial surface. This is the posterolateral surface. This is the medial surface. When we talk about the relations of according to the surfaces, superficial surface is related to strap muscles, mainly sternothyroid, strap muscles, sternothyroid, then sternohyoid and superior belly of omohyoid, which in turn and laterally covered by anterior margin of the sternocleidomastoid muscle. Then in the relations of the medial surface, superior part of the medial surface is related to larynx and pharynx. From this picture also you can see very clearly the superior part of the medial surface is related to larynx and pharynx and to the inferior constrictor muscle. This is the inferior constrictor muscle. And cricothyroid muscles. These are the cricothyroid muscles with external laryngeal nerve between the two. In between these two muscles, there is external laryngeal nerve. So, remember, superiorly, medial surface of each lobe is related to larynx, pharynx, then inferior constrictor muscle, then cricothyroid muscle. Inferior part of the medial surface is related to trachea. In this area, there is trachea and esophagus. Then in between trachea and esophagus, there is recurrent laryngeal nerve. Passes upward in the groove between trachea and esophagus, which lies immediately behind the cricothyroid joint and the ligament of Berry. Then the posterolateral surface. Look at this picture. The posterolateral surface is this surface. It is related to carotid sheath. In this area, the carotid sheath, you can see internal jugular vein and common carotid artery and the vagus nerve. Sympathetic chain, it is behind the carotid sheath and to the prevertebral fascia as well as longus colli directly behind. On left side, the lower pole may closely related to the arch of the aorta as well. Then anterior border is related to anterior branch of the superior thyroid artery. When we talk about the relations of the lobes, other than the three surfaces, superficial or anterolateral surface, medial surface and posterolateral surface, there are two borders we talk about. The anterior border which separates superficial and the medial surface, and the posterior border which separates medial surface and the posterolateral surface. So, the superior thyroid artery, this is the superior thyroid artery. You can see it is coming from the external carotid artery. So it is the first branch of external carotid artery. So this superior thyroid artery is related to the anterior border of the superior border. Then the posterior border, the posterior border is related to parathyroid glands and anastomosis between superior and inferior thyroid arteries. Then we will talk about the relations of the isthmus. Anteriorly, the isthmus is covered from within outwards by pretracheal fascia, then strap muscles, then investing layer of the deep fascia, superficial fascia with anterior jugular vein and the skin. Posteriorly, isthmus rests on second to third or second to fourth tracheal rings. Along its upper margin, the terminal part of the anterior branches of both superior thyroid arteries take part in rich anastomosis, which supplies twigs to the anterior surface of the isthmus also. And then this is the rich anastomosis which forms over the isthmus, the anterior border of the upper margin of the isthmus. Then along the lower margin of the isthmus, the inferior thyroid veins, here are the inferior thyroid veins, they emerge and the thyroidea ima artery, this is the thyroidea ima artery which enters to the thyroid gland. These vascular relations of isthmus are to be kept in mind during tracheostomy. Let's discuss about the arterial supply of the thyroid gland. The superior and inferior thyroid arteries. Here is the superior thyroid artery. Then here you can see the inferior thyroid artery coming from here. from the subclavian artery. Inferior thyroid artery is coming from here. Those two and the occasional thyroidea ima arteries. In some people there is thyroidea ima artery here. Thyroidea ima artery provide rich blood supply to the thyroid gland. Thyroid arteries are large sized and show arterial lobes in order to accommodate the upward and downward movements of the thyroid gland. Superior thyroid artery is a branch of external carotid artery. It descends to the superior pole of the lateral lobe of the thyroid gland, accompanying external laryngeal nerve. The artery enters the gland. The superior thyroid artery enters the gland at the upper pole, but nerve goes deep. Hence, the upper pole is safest site for trying superior thyroid artery during thyroidectomy. That means, imagine this is the superior thyroid artery. Then you have the external laryngeal nerve coming along with the superior thyroid artery to this upper part, upper margin or the upper pole of the thyroid gland. Then what happens is the artery enters the gland at the upper pole. In the upper pole, this artery, this is the upper pole, the artery enters the gland at the upper pole, but what happens to this nerve is it goes more deeper like this. So the upper pole is the safest site. This upper pole is the safest site for tying the superior thyroid artery during the thyroidectomy. Then inferior thyroid artery arises from the thyrocervical trunk. Here is the inferior thyroid artery arises from the thyrocervical trunk of the first part of the subclavian artery, and it forms a loop with upward convexity to reach the level of 6th cervical vertebrae and then descends to reach the base of the lateral lobe of the gland. Then it enters the lower pole of the gland like this, and it is very close to the recurrent laryngeal nerve. At the lower pole of the thyroid gland, it is very close to the recurrent laryngeal nerve. You can see this is the recurrent laryngeal nerve. This is the inferior thyroid artery. So you can see at the lower pole, these two are very closer, this and this. Then what happens if we ligate the artery here? Then you will ligate the recurrent laryngeal nerve as well along with the artery. So you have to ligate the inferior thyroid artery little bit distant to this lobe. That means from this at about this area you have to ligate the inferior thyroid artery when doing a thyroidectomy. That means from these 2 points you have to remember in the superior pole you have to ligate the superior thyroid artery closer to the gland, and you have to ligate the inferior thyroid artery some distance away from the gland. Those two are the points that you have to remember. The important relations with the arterial supply, the nerves, because the nerves coming with these arteries. Then the next we will discuss about the venous drainage of the thyroid gland. The thyroid veins do not accompany the thyroid arteries. Following 3 pairs of veins arise from venous plexuses that lies deep to the true capsule. The superior thyroid veins, this is the superior thyroid vein, then middle thyroid vein, and then finally inferior thyroid vein. Those three pairs are very important. Superior thyroid vein emerge from the upper pole. You can see it is emerge from the upper pole on each side and terminate into the corresponding internal jugular vein. Very short middle thyroid vein emerge from the lobe and terminate into internal jugular vein of the corresponding side. Then inferior thyroid veins emerge from lower margin of the isthmus and descends on the anterior surface of the trachea to open into the left brachiocephalic vein. This is the left brachiocephalic vein. You can see this inferior thyroid veins opening into the left brachiocephalic vein. Right and left inferior thyroid veins frequently communicate with each other in front of the trachea. Injury to these veins is a source of bleeding during tracheostomy. In some people, there are two veins called Goiter's vein. This Goiter's vein is present between inferior and middle thyroid veins, and it is also opens into the internal jugular vein. Remember that there is a Goiter's vein also. Then about the lymphatic drainage of the thyroid gland. The lymph from the upper part of the thyroid gland reaches the upper deep cervical nodes, that means jugulodigastric nodes, either directly or through prelaryngeal nodes. These are the prelaryngeal nodes, either directly to the jugulodigastric nodes or through the prelaryngeal nodes to the jugulodigastric nodes. Then lymph from lower part of the gland reaches to the lower deep cervical nodes, that means jugulo-omohyoid nodes, either directly or through pretracheal and paratracheal nodes, either directly to the jugulo-omohyoid nodes or indirectly through the paratracheal and pretracheal nodes to the jugulo-omohyoid nodes. A few lymph vessels may drain into brachiocephalic nodes in the superior mediastinum as well, and they can reach the thoracic duct directly. This lymphatic spread of papillary carcinoma of the thyroid gland manifests an interesting way. The thyroid gland looks normal, but the deep cervical lymph nodes of the jugular chain is enlarged and contain thyroid tissue. Because of the lymphatic spread of the papillary carcinoma of the thyroid gland. Next, we will discuss about clinical correlations to this thyroid gland. First one is the thyroid swelling, or the name given to the enlargement of the thyroid gland is goiter. Actually, it is the common cause of midline swelling in the neck, and the thyroid swelling moves with deglutition. Remember that it moves with swallowing or deglutition. The goiter may present as a smooth swelling or a nodular swelling. Smooth swelling may be visible during pregnancy. Endemic goiter presents as a large swelling due to deficiency of iodine in the diet or drinking water. In such goiters, they produce signs and symptoms of hypothyroidism. There are sometimes toxic goiters which occur in hyperthyroidism as well as hyperthyroidism or thyrotoxicosis, which manifest the symptoms related to eye, cardiovascular system or the nervous system. The thyroid cancer may be present as enlargement of the gland as well. Some types of thyroid cancer spread by lymph vessels, while other types spread by blood vessels to the distant places like lung, ends of the long bones, skull and vertebrae. Due to this thyroid swelling, there may be pressure effects to the surrounding structures. This enlargement of the thyroid gland tend to compress the structures that are anatomical relations. So, those structures are, there is trachea. So, if the trachea is compressed, The patient may feel dyspnea or shortness of breath. Sometimes esophagus also can be compressed. So, due to that, there can be dysphagia or difficulty in swallowing. Sometimes recurrent laryngeal nerves may be involved. Then you will see hoarseness of voice. If the carotid sheath is involved, there can be posterior displacement, and if the sympathetic chain is involved, there can be Horner's syndrome. During a surgery, you can have the thyroid lobectomy, which consists of removal of a lobe along with the isthmus. Near total thyroidectomy consists of total thyroid lobectomy on affected side with conservation of small thyroid tissue between esophagus and trachea on the normal side, and total thyroidectomy includes removal of the entire thyroid gland. Most common complication of the thyroidectomy is the patient may present with hypoparathyroidism, causing parathyroid insufficiency and low calcium levels in the body. So you have to assess for the complications as well after the surgery. So that's all about I have to discuss today. So if you understood or if you like this video, please put a like and a comment in the comment section, and please subscribe into my channel for more videos. Thank you for watching.